I would like to welcome you all to this webinar. It's the second one of the series from the Pulse of Asia, being conducted in conjunction with the Korean Society of Vascular Research and also the organizer, the publisher Kaga. So it gives me great pleasure, and I think we should get into this directly. Professor Boutouyrie is a medical professor and has expertise in pharmacology. He heads the pharmacology department at the Georges Pompidou Hospital in Paris and has wide experience in hypertension and rare vascular diseases. And so today we're going to hear from Professor Boutouyrie on COVID-19 impact on vessels and T immunity. Pierre, over to you, please.
Thank you very much, Jim. In the next minutes, I will try to show you what might be the consequences of COVID-19 infection on the vascular system. And yeah. So all I will show to you is in the context of the Cartesian study. So you will hear more about this study that we've been able to set up in the past year, thanks to the support of the Artery Society and the support of different structures, including my own hospital. And so what's the rationale for studying the large arteries in after COVID infection? First, it's because the COVID is an endothelial disease, because the target of the virus is the ACE2, which is present on the endothelium. And because COVID, after the acute infection, which might affect the vessels, induces also persistent symptoms of bronchial illness, including cardiac fibrosis, which is known. So the hypothesis that we set up for the Cartesian study is that COVID-19 could induce early vascular aging on the long term following the infection. And so I will just spend some time on what is vascular aging and chronological versus vascular aging. So as you know, everybody is aging because we are getting older every day. And in presence of risk factors such as obesity, type 2 diabetes, infection, inflammatory disease, hypertension, and all the cardiovascular risk factors, it will increase the rate of aging, especially at the level of vessels. And this increased vascular aging, which you might be older than your chronological age, can be something that you can experience after the COVID-19 infection. And the COVID, of course, will increase the vascular aging because of the targeting the endothelium and inducing acute and chronic inflammation in the body. And so this complex slide here is just to remind you that SARS-CoV-2 is a pleiotropic virus because it will enter the body by the lungs, and then it will target directly, because of the S2 spike protein, it will target the endothelium and then affect both the immune system and the acute inflammation, induce cytokine production, which will induce tisular damages, but also will induce chronic inflammation and then can promote the destabilization of coronary plaques and induce myocardial infarction, but also induce heart failure and arrhythmia. So this integrated effect of SARS-CoV-2 is something quite important for the taking into account the future of patients infected with SARS-CoV-2. So it enlightens both the bright side and the dark side of the renin-angiotensin system. So the dark side is the one that we are dealing with when we treat patients with ACE inhibitors or ARBs, which is to decrease the production of angiotensin 2, which is led to vasoconstriction and endothelial dysfunction and inflammation. But on the other side, you know that angiotensin 1 can be catabolized by the ACE2 enzyme, which will lead to angiotensin 1-9 and then angiotensin 1-7, which are vasoprotective. And so you've got a balance in the renin-angiotensin system with the angiotensin 2, induced damage, and the right balance, which is also angiotensin 2 through the AT2 receptors, but mostly the angiotensin 1-7, which is produced by ACE2 stimulation. And then in the presence of COVID infection, ACE2 is targeted and no more functional, so you are losing this vasoprotective effect. So this is a short summary of the effect of SARS-CoV-2 binding to the ACE2, which will inhibit the activity of ACE2 and lead to a decrease in angiotensin 1-7 production, which will lose its vasoprotective effect and induce cardiovascular complication on the long term. And so just to show you how the COVID particles can bind to the endothelium. So this is a complex image again, but you can see here with the arrows, the small dots in which we can identify on the endothelium the presence of the COVID-19 virus. And so this is another example of the presence of COVID effect. Here it's endothelial cells from the pulmonary vasculature. And you can see here the presence of spike protein staining on this 3D view of the endothelium. And just also to show you the effect of ACE2 the presence of COVID on the expression of ACE2, which is markedly decreased at the level of endothelium, and with induction of inflammation through IL-6 production, which is absolutely massive at the site of the endothelium. And so we've got now many papers which show that the acute mortality during the acute phase of COVID infection is massive. And you can see here the frequency of elevation of cardiac troponin 1, which is a marker of myocardial disease suffering, which is markedly increased in non-survivors compared to survivors. The same for BNP, and the same here, I cannot see because of the system, but on the right. So a very strong association of cardiac disease in COVID infection, and this is very linked to the mortality of COVID. So you have here the frequency of arterial thrombotic events outside the heart, and in patients with COVID infection, and you can see here the massive effect on mortality of these arterial thrombotic events. So this hypothesis we think is linked also with inflammation, as we have seen before, with the mechanism of action of COVID-19 because of targeting the ACE2, and also because of the long-term traumatic consequences on the people who have experienced severe COVID infection. And we know the link between the post-traumatic stress disorders and psychological factors on the vascular aging. So you have here just an example of post-traumatic stress disorders, which were persons who were deported in Siberia during childhood and experienced PTSD. And this was linked by Polish colleagues with a very severe PTSD was associated with increased pulse wave velocity compared to moderate and mild. So that's a second mechanism by which COVID-19 can induce vascular damage. Okay, so just to show you here also the cardiovascular risk factors and mortality in hospitalized patients. That's a systematic review which has been published quite recently. And you can see here that the mortality is linked with age, is linked with male sex, is linked with diabetes, hypertension, smoking, all factors which are also associated with increased arterial stiffness and early vascular aging. So that's the association, for instance, of body mass index with COVID infection, with COVID mortality, sorry. So you can see here with hospitalization, ICU admission, and death due to COVID-19 with a nice U shape. Here, people with very lean are also at higher risk, but you can see here this strong association with mortality. And as we know, body mass index is also a risk factor for early vascular aging. So maybe for the sake of time, I will skip some slides, otherwise I will be too long. Just here to show you the association between long-term COVID consequences on the cardiovascular system, coagulation on the endocrine system. And so you can see here that together with the severity of COVID, you've got more acute coronary syndromes, arrhythmias, bradycardia, chest pain, tachycardia, thromboembolism. And that's something which is quite important to see. Okay, so I will probably skip some of these slides which are too detailed. So that's just to show you again the link between COVID infection and cardiac disease. So that's a paper that we've been publishing in my group, in which we studied 48 patients hospitalized for COVID-19. 16 of them had troponin, high troponin level during hospitalization, and they underwent echocardiography at rest and during low-level exercise 6 months later. And we could show that there was very marked abnormalities of the diastolic function with increased E and E prime ratio in patients, which was significant also, and together with increased pulmonary artery pressure, only observed during low exercise and not at rest. So that's an example of the consequences that we can have. So I will come to the Cartesian study here. So this study will identify 4 groups of patients: negative controls, at least at the time of when we performed the inclusions, because now with it's difficult to be certain because of vaccination and the fact that those patients have positive serology when, but even if they did not meet the virus. Non-hospitalized COVID, COVID hospitalized in medicine units and hospitalized in intensive care units with a gradation of gravity between the 4. So what do we study in the Cartesian study? We study, the primary objective is to study early vascular aging by carotid femoral pulse wave velocity measured at 6 months and 12 months, together with, depending on central hemodynamics, flow mediated dilation, carotid radial structure and function, cardiac ultrasound, psychosocial assessment. So those are performed at 2 visits, 6 months and 12 months after the COVID infection, with reference techniques. And dependent centers, we can propose other explorations. So we have 20 countries, 6 continents, 40 centers active, and we've been able to include more than 22,000 patients. In fact, it's 2,465 patients worldwide. And so we are just completing the analysis of the data at 6 months. So just to show you, the bulk of patients is from Italy, Greece, France, Czech Republic, but you've got many other countries which are participating. And the bulk of patients are also non-hospitalized patients with a small group admitted to ICU, which reflects also the severity of the disease, because more than half of them died before having a chance to be included, and 36% which are hospitalized in medicine units. And the controls. And that's the repartition of risk factors. So we've got almost a gender balance. Most of them were hypertensive before. Few current smokers, few dyslipidemia, 30% of hypertension, few diabetes, few established cardiovascular disease. And so we've got a nice proportion, unfortunately for them, with persistent symptoms at 6 months. So there will be a very interesting study of the association between vascular risk factors and long COVID. And 15% of them had vaccination at some times after the infection. So just the baseline characteristics of the patients. So you can see that the patients with COVID are somewhat older than the controls, and even older were hospitalized. And you can see here the risk profiles and the blood pressure, with a gradient of blood pressure also between the controls and the hospitalized or non-hospitalized patients. And so the completeness of the secondary endpoints, you can see here that we've got a lot of interesting data on vascular aging and the questionnaires. And so what are we doing now? So we are waiting for the final paper to have all the investigations done at 1 month, at 12 months. And we aim to apply new precision techniques to assess the data, in particular data machine learning, and apply some mathematical models on waveforms to know more. So as a conclusion, we can say that COVID-19 is closely associated with cardiovascular disease, both risk factors for severe cardiovascular COVID infection, and as a potential trigger for incident cardiovascular events. So that's from the literature. And that there is a high risk of a big amplitude wave of cardiovascular disease long after the COVID infection. And so we fear to have a second pandemic of cardiovascular disease following COVID-19 infection. And that by identifying correctly the patient at high risk of developing cardiovascular disease, we can prescribe preventive medicine and better identify those patients. So sorry, I've probably been too long, and thank you very much for your attention.
Pierre, thank you very much. Pierre, can you hear me?
Yes, I do.
Thank you very much for the great presentation and the incredibly interesting study that you've got going there. Sorry, I'm just sharing webcam here. Pierre, fantastic study, really very, very topical. We, unfortunately, due to technical difficulties, can't have much time for questions, but the standardization of this study, to what extent is it standardized across all those centers in terms of the blood pressure measurement and the clinical characteristics of these patients? Because there's clearly going to have to do a lot of statistical correction for potential confounders. Is that something that's very, very closely controlled in this study?
Yes, thank you, Jim, for this excellent question. This is of course a key factor. So we had the guidelines as for blood pressure measurement to get it standardized. So the one we use as a reference is the one we get during the hemodynamic measurements, and so we recommend to measure every 3 minutes and to use the blood pressure between 15 and 30 minutes of examination as a mean, and calculate the mean as the true blood pressure value. So we recommend also to use the same blood pressure monitors, and we check that people use that, which is an Omicron. Don't remember the reference, but that's an Omicron device. And we recommend to use validated techniques for pulse rate velocity measurements, which includes Sigmocore XL, Complier, Bicorder, and but we allow, of course, centers who use brachial ankle pulse rate velocity, for instance, to provide the data, but of course they will not be mixed with the carotid femoral. And beside that, we have tried with each center to work on the procedures for endothelial dysfunction and on all the measurement that have been done. And we had also the help of Adcore Medical for standardizing the pulse wave analysis. But I agree with you that it's a lot of work to check all this data. We've got a centralized CRF also, which is under REDCap, which allows to check a lot of things. And we've got a research assistant who is working on a daily basis with centers to solve all these issues. So that's tough because we don't have much money to do it. But,
Never do.
but at least we do our best to get it standardized.
Yeah, can you tell us quickly, what do you expect with respect to the influence of treatment on the outcomes for early vascular aging and indeed long COVID itself? What would you hypothesize?
So what we think is that we should concentrate on taking care of all the treatable risk factors, even if mildly elevated, following COVID. So by using probably drugs which are valid and which have shown to make arterial stiffness regress in the past. For instance, drugs, the RAAS blockers and drugs like this, and also to promote physical exercise, to promote all the non-pharmacological ways of treating risk factors. And so in short, to have a very proactive, intensive care for these patients, even if blood pressure is mildly elevated, even if body weight is mildly increased, but at least to be proactive for taking care of these risk factors. And we expect to slow down the process of early vascular aging.
Fantastic. And what would you hypothesize the role of vaccination could be on your outcomes with respect to early vascular aging?
That's a complicated question. First, vaccination has been great for preventing severe COVID, at least in our countries. And it's complicated then to have a true status regarding the COVID infection because of the positive serology, so we cannot use that. And we know that that vaccination for flu or vaccination for typhoid in the past have been associated with temporarily increased arterial stiffness. So here we are at least 1 month after vaccination for the investigation. So we should not have this acute effect of vaccine. And by decreasing the severity of the COVID infection, and by decreasing the virus load of the patient infected, we think that the vaccination might be protective against the long-term vascular consequences of COVID. But I'm not sure we will have the means to prove it in the Cartesian study. It should have been done with another design of study if we wanted. And at the time when we decided to do the Cartesian study, the vaccine was not available. And so we could not include that in the, and after that it was too complicated to change the design.
Yeah. Well, look, Pierre, congratulations. Thank you so much for this talk. It's great to hear what you're doing, and we look forward to those results. It's wonderful to see you after all this time from Paris.
Right.
Thank you. Thank you again for this great presentation, and we're going to have to move on. So I'll say au revoir.
Everybody, thank you.
Thank you, Pierre. And if I could just make mention to anyone who has a question, please just go ahead and put that in the chat. It now gives me great pleasure to introduce Professor Eui-Cheol Shin from Daejeon, Korea. Sorry. He's currently professor at the KAIST, College of Life Science and Bioengineering. He graduated from the Yonsei University College of Medicine, and his major studies are on T-cell immune responses in viral diseases and immunologic diseases, and on developing T-cell vaccines. And he's recently published a series of papers related to T-cell orientated strategies for controlling the COVID-19 pandemic. And his topic today is immune responses in COVID-19 and hyperinflation. So if I could hand over to you now, Professor Shin. Thank you very much.
Yeah, thank you for kind introduction. Can you see my screen now?
We can.
Thank you. Great. Yeah, today I'm going to talk about the immune response in COVID-19 and hyperinflammation. So I don't need to emphasize the impact of COVID-19 here. And as a while ago, Pierre, he mentioned about the cardiovascular feature of COVID-19. And as you can see here again, the COVID-19 is not just pulmonary disease. It's kind of systemic disease affecting multi-organ, including cardiovascular system. And this schematic diagram is showing just the possible mechanism how the SARS-CoV-2 virus can affect the cardiovascular system. But today, so by myself, as an immunologist, I'm going to talk about the two different mechanisms. The first one, the hyperinflammation. So actually there's no doubt that all kinds of the multi-organ complication is basically caused by hyperinflammation. In other terms, cytokine storm. And this cytokine storm is mainly mediated by TNF-alpha, IL-1, and IL-6. And today, I'm going to show you some data about the additional factor in addition to TNF, IL-6, and IL-beta. So I'm going to show you those kind of our paper. And the second one, in the cardiovascular system, the microvascular thrombosis. In other terms, immunothrombosis is one of the common features of the COVID-19. And I'm going to show you very briefly a mechanism of what's at the center of the microvascular thrombosis today. So at first, let me introduce the cytokine storm in COVID-19, hyperinflammation. But basically, I don't like the cytokine storm, this term, as an immunologist, because too broad, not so specific. So now, this schematic diagram is showing very nicely the broad range of the cytokine storm syndrome, not just for COVID-19, but yeah, not only viral infection, even it includes sepsis, even some macrophage activation syndrome, even it includes also hemophagocytic some lymphohistiocytosis, for example. So kind of the broad range of this not so specific term. And this one is also showing from another review paper, is showing again the broad range of this cytokine shock or cytokine storm syndrome, caused by not only virus, but also bacterial sepsis or like that. But one of the common features of this cytokine storm syndrome regardless of the causative agent, it induces hyperactivation of innate response. As you know very well, there are two different immune systems, adaptive and innate. But mainly, this cytokine storm syndrome activate innate response. And this innate, highly exaggerated innate response can cause host cell damage, and it can further exaggerate this cytokine storm loop. In that way, there's some positive feedback for the system, and finally, systemic inflammation can occur, and then affect multi-organ, several organs, including cardiovascular system. And I already told you that in this cytokine storm syndrome, TNF-alpha, IL-6, and iron beta at the center of this cytokine, the storm syndrome, irrespective of this the causative agent. And then, you know very well how initially this innate response can be activated during viral infection. Then first system is the TLR system. And TLR system finally, by activation, NF-kappa B and IRF3 will be activated. And then finally, as the downstream gene, one of the most important one is TNF-alpha and IL-6. And second important one is the inflammasome signaling. With this, the inflammasome activation, the iron beta, by the cleavage of the proteolytic cleavage of iron beta, pro-iron beta, the active form of iron beta will be produced. So in that way, so three major cytokines can be generated by toll-like receptor signal and inflammasome activation. But a few minutes later, I'm going to show you the type 1 interferon is also important in addition to these three major cytokines. I'm going to show you, especially in COVID-19. And also, briefly, I'm going to show you how this immunothrombosis, microvascular thrombosis can occur. And in the several COVID-19 research, in the early research, they show that they successfully demonstrate that the neutrophil is at the center of this immunothrombosis, intravascular thrombosis. And especially neutrophil can release NET. I'm going to show you the NET. What's NET? But anyway, the NET is one of the initiating the event of this thrombosis. So you may not familiar with this the neutrophil extracellular trap, NET. So recently, not only in COVID-19, but also any other inflammatory disease, the role of NET released by neutrophil is getting more important topic for the research topic. And now I'm showing you from one of the basic immunology textbook. I'm going to show you what's the NET. So now you can see the neutrophil, and what's this kind of the NET, like the structure is DNA. Their DNA. So it means that neutrophil, when they meet the bacteria or other some pathogen, then they release their own DNA. By releasing their DNA, they'll die. But anyway, the DNA basically sticky material. So this sticky DNA can trap the bacteria or some other pathogen. So we call that this one neutrophil extracellular trap. It is basically the DNA, and this NET is one of the major effector mechanism of this neutrophil. But now I'm showing you from one of the literature. This one is just a capture of the picture of just a patient, COVID-19 patient blood in very severe patient. Now you can see without any in vitro treatment. Now you can find that the green color is showing the DNA, the released by neutrophil. So this NET is the very actively formed in the COVID-19 patient, especially with the critical or severe patient. And now there's many people believe that the NET is at the center of the immunothrombosis, the initiating event. So the NET can induce the several events, including this cardiovascular complication. Due to this reason, so this is from one of the review article. Some of the drug candidates targeting NETosis or NET on the clinical trial in the COVID-19 for the treatment of COVID-19. But especially you can find a very interesting material. For example, such kind of NET degrader is a kind of the DNA, basically. This DNA is now under the clinical development to reduce the NET, the burden of NET. In that way, they can reduce the immunothrombosis. So anyway, so far, I just briefly reviewed what happened in the hyperinflammation, and also what happened in the neutrophilic activation and possible impact on cardiovascular system. And from now, I'm going to show you our own data, but it's not cardiovascular the data, but I'm going to show you some of our immunological data, what we obtained from the COVID-19 patient by performing single-cell RNA-seq analysis. Actually, we did the analysis at the beginning of pandemic. So we already published this data in the July issue of Science Immunology in 2020, around 22 years ago. But in that time, we performed single-cell RNA-seq analysis after obtaining the PBMC from mild COVID-19 patient and severe COVID-19 patient. And then we performed the single-cell RNA-seq analysis. And yeah, to save time, I will skip this in detail some analysis. But I want to emphasize this very unique part. Actually, the red color is showing flu patient, and blue color is showing the COVID-19 patient, especially dark blue is the severe COVID-19 patient. And then, actually, the hierarchical clustering of this differentially expressed gene, it resulted in that the irrespective of cell type, the specific gene regulation and COVID-19 specific gene regulation, it was clustered separately. But only this thing is overlapped between the severe COVID-19 and severe influenza. It kind of could be found in the monocyte. So we conclude that maybe not in mild COVID-19 patient, but severe COVID-19 patient monocyte resembling the severe influenza monocyte. And what's that component? That was our next question. And I will skip the in detailed analysis. And this is our conclusion. The severe influenza is characterized by type 1 interferon feature. But mild COVID-19 is characterized by TNF and iron beta. But severe COVID-19 have the coexistence of TNF, iron beta, and type 1 interferon. So actually, severe COVID-19 are characterized by combination of this. In addition to this, the mild COVID-19 feature, there's some addition of this type 1 interferon feature. So we hypothesize that this maybe type 1 interferon is a kind of the additional factor for the exaggerated inflammation, in addition to TNF and iron beta. And this one is kind of the very unique feature of single-cell RNA analysis, trajectory analysis. So in this way, we followed a single patient who developed from mild to severe disease, and we found that the interferon alpha feature could be found only in the severe stage in a single patient. And finally, by some gene set enrichment assay, we conclude that we suggest that why this type 1 interferon can exaggerate this hyperinflammation. So actually, our conclusion is this one. So previously, it was well known that TNF is the pro-inflammatory cytokine, but at the same time, it has the LPS tolerance effect. So kind of negative feedback mechanism. But typically, type 1 interferon can abrogate the LPS tolerance effect of TNF. So this the cluster 1 gene. This one is the previously reported such kind of the interferon-mediated abrogation-related gene set. And this cluster 1 is nicely correlated with our severe COVID-19 patient gene set. So we conclude that interferon type 1 induced hyperinflammation by abolishing a negative feedback mechanism of TNF-alpha. So this is kind of schematic diagram. So this is summary of our own data. And finally, so we could conclude that type 1 interferon can exaggerate the inflammatory response. But it was the 2020 July. But in that time, many people reported about the good aspect of type 1 interferon as an antiviral mechanism. So the study before my publication, they reported impaired type 1 response in severe COVID-19 patients. But for the first time, we reported that type 1 response is very vigorous, robust in severe patients. So, but after our paper, several papers also confirm our result, and now the consensus is like this. The early robust type 1 response resulting in mild disease, but delayed exaggerated type 1 response resulting in severe disease. But also, the opposite case, the deficiency in target internal response due to some genetic defect. In that case, due to the absence of target internal response, the severe disease. It means that two different extremes. It means that absence of target internal or the delayed but exaggerated target internal response can result in severe disease. And from now, I'm going to show you very briefly this the therapeutic, our target. So as you know very well, this is the Paxlovid now targeting this protease, and the molnupiravir is targeting RNA-dependent RNA polymerase. But other strategy for the treatment of severe patient is anti-inflammatory agent. So including tocilizumab or baricitinib, well, but more common one is dexamethasone. So dexamethasone, but sure, dexamethasone save many patients' life during this COVID-19 pandemic, but we don't know the exact mechanism. So the conducted single-cell RNA analysis again, and especially with the sample with the dexamethasone treated patient. And I'm going to show you the conclusion. Just we found that the dexamethasone treated patient showed the downregulation of ISG. You may remember that in my first study, we showed that interferon response is exaggerated in severe patient, and corticosteroid treatment can reduce this ISG. But we also found that this is mediated by direct downregulation of STAT1. And this is a very interesting part of my study. So it is already well known that SLE, the lupus erythematosus, the systemic lupus erythematosus, is one of the well-known the type of interferon-related disease. And we found that this the dexamethasone regulated interferon stimulate gene, it is overlapped with the gene signature of SLE. So now you can see that we just reanalyzed the publicly available the data from the previous literature, and especially this one. This part is related to the severity of SLE, and nicely overlapped with the gene set of the dexamethasone down-modulated gene set. So we conclude that the corticosteroid treatment suppress lupus-like dysregulated interferon response in severe patients. And for the several slides, I'm going to show you a little bit different part of the talk. So far, I talked to you about the hyperinflammation and down modulation of this hyperinflammation by corticosteroid. Well, from now, I'm going to a little bit talk about the T cell. What T cell then? T cell is good player or bad player? In certain the review article, they are saying that T cell maybe some cytotoxic T cell can exaggerate the host damage during COVID-19, but that's not the case. So already, especially in the respiratory viral disease, it is already previously known that adaptive immune cell in T cell even directly down-modulate innate immune response, somehow kind of negative mechanism. It means that if T cell is strong, then the innate immune response, cytokine storm, can be suppressed. But it happened just by reducing the amount of PAMP viral load by T cell. Then the stimulator, this PAMP, is reduced. That's one of the mechanisms. So it means that if we, by vaccination, for example, if we boost T cell response or neutralizing antibody response, then maybe we can attenuate during the breakthrough infection, we can attenuate the innate immune response, and we can prevent cytokine storm. We can just hypothesize that. But then now we are in the Omicron era. But what's the impact of Omicron? Omicron, so now I'm showing you here, after 2-dose vaccination, the Omicron can reduce the neutralizing antibody activity by 20 or 30-fold reduction. It means that it's a huge evasion. So it means that the neutralizing antibody cannot prevent the Omicron infection, especially in the 2-dose vaccination situation. Then how about the T cell response? So now this is our paper. So now it will be published next week. And we found that after 2-dose or 3-dose vaccination, we analyzed T cell response. And ancestral strain specific T cell response, it means Wuhan specific T cell response is like this. And then if we perform analysis by using Omicron, the specific one, a little bit reduced, but substantially responding to the Omicron virus. It means that T cell can do something against Omicron infection. This is one of the rationale why we need to continue the vaccination in the Omicron era. So now I'm showing you again, is the T cell oriented strategy. So now antibody is have a short longevity, but T cell have a long lasting longevity. And for the variant, T cell is much more durable. So now for the preparing for the controlling the COVID-19 pandemic, we need to think much more about the T cell, not only the neutralizing antibody, but also T cell response. Maybe this is the end of my talk. I think so. Yeah, this is some long COVID mechanism now I'm showing you. One of from the review article. So long COVID affecting not only cardiovascular system but also any other system. But there are three major theoretical hypotheses. The first one is viral persistence. Second one is persistent inflammation. Third one is autoimmunity. So for the further study is required to reveal what kind of mechanism is responsible for what kind of complication, the long COVID. So yeah, we need further research about that. Yeah, thanks very much for your attention.
Professor Shin, thank you very much for that. Can you hear me, Professor Shin?
Oh, sure. Yeah.
Thank you very much for that excellent talk. You've done an amazing amount of work in this area. And I'm just wondering, you did touch on in the end there some of the potential mechanisms in long COVID. A lot of your work's in the acute inflammatory response. There looks like there's a bit of overlap in some of those mechanisms in long COVID and the inflammatory response. Would you ultimately seeing similar potential therapeutic targets or for long COVID versus acute COVID?
Yeah, so we don't have any enough strong evidence for what kind of mechanism for what kind of long COVID complication. But already told you that three different possible explanation. So I think that hypothetically we think just one by one a little bit differently. For the viral persistence, we need more vaccine or even for neutralizing antibody, even for the antiviral as well, for example. But for the persistent inflammation, we need like the anti-inflammatory agent, like steroid or some IL-6 inhibitor, for example. But I think that most difficult one is autoimmunity. The several studies now showing that the autoantibody developed after recovery from the COVID-19. In that case, little much more hard. Yeah. So what kind of antibody? So we need to get some profile among the convalescent patient, what kind of autoimmune antibody develops. So, but that's a much more tougher, I think. Yeah.
And do you think that in some ways that you're going to learn more about the mechanisms of current existing problematic diseases such as chronic fatigue syndrome that seems to carry the hallmarks of long COVID? Are you going to be gaining more important information as to how that problem could be addressed and treated?
Just my private idea, the opinion, is that the chronic fatigue is related to chronic inflammation, kind of persistent inflammation. Actually, by collaboration with some ID doctor in Korea, I followed very unique patient case, very unique, very interesting patient. This patient recovered from the COVID-19, but for 1 year, the serum LDH level is very high, LDH. It means that LDH high, not normalized at all for 1 year. But she felt the chronic fatigue like that. But we couldn't find some specific target organ of this as a source of this elevated LDH. So I think that not liver, not heart like that, but somewhere in her body, some small level of the persistent damage, whole cell damage, it occur. So now 1 year later, now getting normalized now. But now chronic fatigue symptom is getting better now. So not for every case, but for this certain case, LDH could be some good marker for the kind of biomarker. Yeah, but not for all patients.
Yeah. Very interesting. Look, I'm Professor Shin. Time is against us. I'm not sure if we have any other questions from either Professor Boutouyrie. I'm not sure if Professor Park has audio.
Professor Shin, but congratulations for your excellent presentation. Quite impressive, the work that you've been doing.
Thank you very much.
Indeed it is. Now, I'm going to hand over now to the organizer from CARGA, Ines Silva Perez, to conclude the meeting. And again, I'd just like to finish by thanking so much the speakers, Professor Shin, Professor Boutouyrie, fantastic, cutting edge information for this wonderful webinar, organised by Zhong Bei as usual and others. Greatly appreciated, and a real shame we couldn't hear from you directly tonight, Zhong Bei. But now if I can hand over to Ines to conclude the webinar, and thank you again.
Yes, thank you very much. First of all, on behalf of Professor Zhong Bei Park, let me thank both speakers for great presentations, and Professor James Sarman for sharing in the face of technical difficulties and engaging discussions that followed the presentations. I would like to mention that the 2022 highlights from Pulse will continue throughout the year. The next webinar is planned for July 1st as a satellite event of Pulse of Asia 2022, happening on July 2nd. We are greatly excited about that one, and we hope to count with your presence there as well. Thank you very much for all for attending, and have a great evening, day, depending on your time zones.
Yeah.
Thank you very much.
Thank you very much.
Bye.